Vamos dar início então, pessoal. Bom dia. Bom dia a todos. Nós estamos iniciando hoje o primeiro Grand Round do ano. E realmente eu queria fazer algumas palavras rápidas para colocar a vocês a importância desses eventos de Grand Round e a sessão anatomoclínica. Nas 3 primeiras quartas-feiras do mês nós temos um Grand Round que com vários formatos, com vários convidados, com vários serviços participantes. E na última quarta-feira do mês, geralmente nós teremos um anatomoclínico, uma sessão anatomoclínica. Esta sessão de quartas-feiras às 11 horas é a sessão da instituição Hospital de Clínicas. Então estão todos convidados. E eu gostaria que vocês que estão aqui presentes agora multiplicassem o convite para os seus colegas, em todas as áreas. É um evento multidisciplinar, didático, educativo, e muitas vezes ele gera até protocolos assistenciais e modificações de condutas dentro do próprio Hospital de Clínicas. Então esse é um evento muito importante que vocês têm que procurar participar. Nós podemos conversar, já conversamos, mas podemos conversar para vocês serem liberados das atividades, os alunos serem liberados das atividades didáticas deste momento, das quartas-feiras às 11 horas. Nós sempre encorajamos a Faculdade de Medicina, a Escola de Enfermagem, para que liberem, e as outras escolas, que liberem os seus alunos nesse horário, que não marquem nenhuma atividade específica nesse momento. Nós encorajamos os serviços aqui do Hospital de Clínicas a não marcarem as suas reuniões neste horário. Existem vários outros, nós só pedimos 1 hora por semana para termos esse momento, que é um momento muito importante. Então eu convido a todos a comparecerem aqui às quartas-feiras, às 11 horas. Nós vamos procurar iniciar no horário antes, então é 11 horas que nós vamos começar. Então nós vamos nos preocupar muito com o horário e procurar terminar ao meio-dia. Então, como primeira do ano, nós temos um convidado internacional que vai ser apresentado pelo professor Ricardo Savares. Semana que vem nós teremos a aula inaugural da Faculdade de Medicina, só que ela inicia às 10 horas, não vai ser às 11 horas. Então, quarta-feira que vem, inicia às 10 da manhã com um professor homenageado que vocês verão nos cartazes. Então, por favor, divulguem esse momento, às quartas-feiras, às 11 horas, para todos os colegas de vocês, residentes, professores, todo o pessoal do hospital. Tá? E vocês verão os cartazes de qual assunto, certo? Então, eu passo agora ao professor Ricardo Savares para fazer a apresentação. Obrigado.
Muito obrigado pela oportunidade. Eu gostaria de agradecer a direção do Hospital de Clínicas pelo Grand Round. E hoje tenho o prazer, o Dr. George Sawaya, ele é da Universidade da Califórnia, em São Francisco. Ele é um ginecologista e obstetra, e também responsável pelo setor de colposcopia da Universidade da Califórnia. Ele faz parte da Força Tarefa Americana para tratamento de prevenção. Então, todos os guidelines que o governo americano estabelece, ele fez parte, tem experiência nisso. E ele vem aqui com uma bolsa da CNPq, ou seja, não tem nenhum conflito de interesse sobre a vacina HPV. E ele vai falar sobre a vacina tetravalente, que existem 2 no mercado, que uma é bivalente, outra é tetravalente, que ele vai comentar sobre isso. Certo? Então, com a palavra, o Dr. George Sawaya, que ele fala somente em inglês, mas o inglês dele é muito claro, espero que todos consigam entender. Professor George Sawaya, please.
Thank you, Ricardo. I suppose I should say thank you. I have no idea what you said. But it's certainly my pleasure to be here. It's my honor and my privilege to be in Brazil, my first trip to Brazil. And so far it's been a lovely experience and meeting a lot of really wonderful people and a lot of like-minded thinkers. I'm going to talk about human papillomavirus vaccination, which you may have heard a lot about. There's a lot of information about this. I want to first of all tell you that there are really two main vaccines that are available, but only one is available in the United States. So I'm going to only talk about that one vaccine that's available in the United States. It's called Gardasil, and it's a vaccine that includes antibodies against 4 oncogenic, or I should say 4 HPV types. So I just want to start out by being clear about what I'm going to be discussing. I have no conflicts of interest. I think this is always an important slide to show. I'm going to start out by having you vote on various options for what you think a guideline should be for HPV vaccination. Now, at this point, it could be based on anything you know about HPV vaccination. Things you've read in the newspaper, things you've heard on television potentially, or even things that you may have read in the scientific literature. So I'm going to have you, first of all, think about all these 4 options before you vote, but I'm going to ask you all to vote. So the first is to vaccinate all girls and women aged 11 to 12 up to the age of 26. The second is to vaccinate all girls and women aged 11 to 12 to the age of 18. The third is to vaccinate virginal girls or women aged 11 to 12 up to the age of 26. And the last option is to not do any vaccination at this time. So I'm going to ask you, first of all, how many of you would choose option number 1? So there are a few option 1s. What about option number B? Some enthusiasm for that. What about option number C? So lots for that. And what about option D? Some for that. This is I've done this exercise many times in many audiences, and I can tell you that the response is very identical. There seems to be a lot of mixed answers. So some people, it seems to be kind of no consensus of opinion about this. The reason why we did this actually is we're trying to come up with a guideline for my hospital in terms of vaccination. And so we did a session like this with the medical students and with others and tried to figure out if we can come up with a guideline. And again, we didn't have a lot of consensus about this. So let me just give you some brief background. Human papillomavirus is a small DNA virus. It causes hand and foot warts, but there are also some types, about 30, that are trophic for the lower genital tract. HPV causes a variety of diseases in humans, ranging all the way from anogenital warts to lesions of the lower genital tract in females, cervical, vulvar, and vaginal cancers, and anal cancers. It also is the cause of some very rare but very devastating pediatric illnesses, and also has been implicated in oropharyngeal cancers. So certainly anything that would be able to primarily prevent HPV infection may have a profound impact on all of these diseases in humans. I'm going to tell you the story about HPV because it's a beautiful story of medicine. And it's actually such a compelling story that it won the Nobel Prize. Zerhausen won the Nobel Prize last year for medicine because of his active involvement in this story. In the 1960s, there were a lot of associations between cervical cancer and sexual transmissibility. So people were wondering why there were certain groups of women who were very prone to cervical cancer and others who were not. And they were noticing that women who were commercial sex workers had a higher incidence of cervical cancer, and that other groups of women with very few sexual contacts, like nuns, for example, all had very low risks of cervical cancer. So there was some thought that it had to do with sexual activity. In the 1970s, there was evidence that a virus was implicated here, but it wasn't clear whether or not it was herpes simplex virus or even human papillomavirus. But in the 1980s, there were multiple epidemiologic studies that showed that HPV was highly associated with cervical precancerous lesions as well as cervical cancer. And there were several types of HPV specifically that were implicated in oncogenesis. In the 1990s, HPV testing was found to be highly sensitive for cervical cancer precursors. It wasn't very specific, but it was highly sensitive. And in the 2000s, once we had this established, there was so much excitement and enthusiasm that it was a virus because we know how to make vaccines against viruses. So you see how that's a very compelling story. In the 2000s, there was development of a vaccine targeting the highest risk type HPVs, and I told you that in 2008, Zerhausen was awarded the Nobel Prize in Physiology or Medicine for work in HPV and cervical cancer. Now, you see how this is a very compelling story of modern medicine. We didn't know what caused a particular disease. We found that it was a molecular entity. We did lots of bench research, so it went from the population to the clinical laboratory, and then the fruits of the clinical laboratory became something that was useful for a population. So it's a really very compelling story of medicine, and not many fit into this mold, but this is really quite compelling. This is a schematic that shows how we believe that HPV causes cervical cancer. HPV infection is extremely common in young women after becoming sexually active, with a prevalence or incidence rate of 40% in the first 1 or 2 years of becoming sexually active. So it's almost impossible to avoid HPV altogether if you're sexually active, certainly, and it's more so in some geographic areas of the world. So HPV, there's an initial infection on the normal cervix. The normal cervix is brilliant. It knows very well how to deal with outside invaders because, as you know, it has to protect the peritoneal cavity, and the cervix is the entry into the peritoneal cavity. So it has an incredibly robust immunologic mechanism to deal with outside pathogens. So most of these pathogens are dealt with at the level of the normal cervix, and these infections are cleared. Some unfortunate individuals will have an HPV infection of the cervix that will persist, and that's thought to be a risk factor for progression to precancerous lesions. These precancerous lesions are what we screen for and treat with cervical cancer screening through pap smears. And by treating these precancerous lesions, we avoid invasive cancer. And that's how our efficacy for cervical cancer screening is realized. Now, we also know that some of these precancerous lesions will go away on their own, and some will actually turn back to a normal cervix. We can't make that prediction very well. So you can imagine anything that blocks HPV here would protect from this downstream effect. This is a schematic showing that of all the cervical cancers that occur in the world, 70% are due mainly to HPV type 16 and 18. So these are why these particular oncogenic types have been targeted for a vaccine. So I'm going to give you the vaccine timeline. In May 2005, the first phase 2 trial was published of the quadrivalent vaccine. This is the vaccine called Gardasil. And this is a small trial. I'll give you the results of that trial in just a moment. About a year later, the Food and Drug Administration of the United States approved the tetravalent vaccine that targeted types 6, 11, 16, and 18. As I told you, 16 and 18 are causes of cervical cancer, causes about 70% of cervical cancers. Type 6 and 11 cause warts. So the goal of this vaccine is to decrease anogenital warts and to decrease cervical cancer precursors and cervical cancer due specifically to those HPV types. The Centers for Disease Control in the United States has a branch called the Advisory Council on Immunization Practices, ACIP. They published provisional recommendations for the use of Gardasil. Then 2 months later, the American College of Obstetricians and Gynecologists, which is our professional society in the U.S., endorsed the ACIP guidelines. And then in January 2007, the American Cancer Society made their recommendation. And then in March of 2007, the ACIP made their final recommendations. Now, I will tell you, up to this point, there had been no publication of the phase 3 trial results. Now, phase 2 trials are randomized trials that are placebo-controlled, that are dose escalation trials, often trying to figure the right dose and trying to figure safety out to some degree. But it's really the phase 3 trials that are the large randomized trials that give us the best idea about safety and efficacy. So up to this point, although we had a lot of recommendations in the United States, no one in the academic community could actually see any of the results. The results were just in the package insert for the vaccine, and the results were in FDA documents that were available on the website, but they weren't available in any peer-reviewed publications. Then in May of 2007, we had interim phase 3 trials that were published. Now I want to point out that these were interim results. These were not the final trial results, but they were the results after 3 years of the 4-year trial. And I would say that up to this point, it was very difficult for those of us in the academic community to answer questions about HPV vaccination because we couldn't see any of the data. So it was very difficult for us to make an evidence-based type of a response. But then once we got these interim results of the phase 2 trials that were published, we were able to actually see some data. So that became quite helpful to us. I'm going to explain to you how the study is done and how I should say studies, because there are 2 main studies, how they're done and how the results are reported, so that you might be able to understand a little bit better some of the complications or the complicated factors that go into doing studies and interpreting studies. But also it might help you understand a little bit better some mixed messages you may hear about the vaccine. So these were large randomized trials. They included largely women who were not virgins, women who had had prior sexual intercourse. But of course, it wasn't clear whether or not the vaccine would help women who already had an HPV infection, or whether it would only help women who had never been exposed. So what they were able to do in the trial is to identify the women in the trial who had no evidence of being exposed to certain HPV types. And this was by doing PCR testing of the lower genital tract and also by doing serology testing. Now, I'll just tell you now that clinically we are unable in the United States to do that type of testing because these tests are not available. So we can't really replicate some of these findings. But in this one subgroup amongst all randomized women, this was called the per protocol susceptible population. These women were naive at entry for relevant HPV types and throughout the vaccination period. They got all 3 doses, they had no major protocol violations, and they started counting the cases at month 7. So there were some exclusions after randomization, which sometimes can be a problem. And there was also some differential exclusions in one group versus the other group by the time of analysis because they didn't start counting cases until month 7. Something to just consider. The second population that they described was called the unrestricted susceptible population. These are women who were naive at entry for these relevant HPV types and got at least 1 dose of the vaccine. They didn't get all 3 doses, they had some protocol violations, but they at least got 1 dose. And then of course, when we do randomized trials, everyone is interested in the intention to treat population, and that is everyone who is randomized, no exclusions, regardless of how many doses you got and regardless of what your status was at the beginning of the trial. Now this trial also was very clear that they wanted their main outcome to be HPV-related disease amongst women who were naive at entry. So they declared that at the beginning to the FDA that that's what they were interested in. So this, the results are also given in terms of two different outcomes. One is disease associated with HPV vaccine types. So this would be CIN, or cervical intraepithelial neoplasia, associated with types 6, 11, 16, or 18, for example. But there's also another outcome. It's disease associated with any HPV type, regardless of HPV type. And that answers the question about if a woman is vaccinated, what's her chance of getting cervical cancer precursors, regardless of what type of HPV is causing it. Okay? So those are the two different outcomes. So first of all, I want you to notice that we have 3 different populations and 2 different outcomes for each of the populations. So this is why it's a little complicated, but when I go through the trial results, I'm going to give you all of this information. For those of you who are not very familiar with cervical cancer screening, I added this slide. This explains why these particular outcomes were chosen for the trial. First of all, we would be very interested in the outcome being cervical cancer. But cervical cancer is very rare, especially amongst young women. So to find cervical cancer as an outcome, you would have to randomize literally hundreds of thousands of women and follow them for a couple of decades or so to see any difference between the two groups, because cervical cancer is such a rare disease, especially in screening settings, because we screen for it, we find it, and we treat it, so it becomes really quite unusual to find. So, in the absence of being able to measure cervical cancer, there has been enthusiasm for measuring cervical cancer precursors as being a surrogate for cervical cancer. So the question then is, which one is the right surrogate for cervical cancer? Well, CIN is graded 1, 2, and 3. CIN 3 is also known as carcinoma in situ. It is the most proximal cancer precursor. I think everyone would agree with that. Now, CIN1 indicates an active HPV infection, and we find it clinically, but we don't treat it in the United States because we feel like it's mainly a transient state. We don't like to treat things that are going to go away on their own. CIN2, most of these are treated, but we also know that about 40% of these go away on their own as well. So we try not to treat this in patients who are young, who haven't started or completed their childbearing, because some of our treatments may have adverse effects on obstetrical outcomes. Some of our guidelines say that we can just follow CIN2 in young women. Then the last cervical cancer precursor is adenocarcinoma in situ. It's widely considered to be a cancer precursor, but it's very rare. But that would certainly, no one would argue that that is an important lesion that needs to be treated, and certainly would be an important lesion to prevent. I told you I would tell you the phase 2 trial results of Gardasil, and here they are. This was a double-blind, placebo-controlled trial sponsored by Merck, who's the maker of the quadrivalent vaccine. This trial was fairly small, only 552 women in the trial. If you look at a modified intention-to-treat analysis, this is everyone in the trial, they found very encouraging results. They found that there were no cases of CIN associated with the vaccine HPV types amongst women who were vaccinated, compared to 7 in the placebo group. So that was very encouraging. They also showed a decrease in external genital warts. When they did the per protocol analysis, which is that smaller group, the naive women who had no protocol violations, they also found a large difference. This is CIN associated with vaccine HPV types. This is a smaller group of women, so a fewer number of outcomes, but again, very strong protection. It's hard to say very strong protection when you only have 3 outcomes in one group, of course, right? So that doesn't really have a lot of clinical meaning, and there's a lot of imprecision around this analysis. But no mind, because that's a phase 2 trial. They're not powered to show differences. So this is where the phase 3 trials are important, and those are larger trials that I'll tell you about now. So these are the 2 phase 3 trials. They're called Future 1 and Future 2. These included women of these age ranges. What you'll need to note is there are no women in these trials that are under the age of 15. So if you're interested in knowing clinical outcomes in women under the age of 15, for which many of the vaccine guidelines target, then you will find that there's really no direct evidence about clinical outcomes in that group. These trials are large. This Future 1 is 10 times larger than the Phase 2 trial, and Future 2 is 12,000 women. These are done all over the world. Some women, there were some exclusions. So anytime you have exclusions, you have to think about who the results are going to generalize to, right? So, of course, pregnant women are excluded from most intervention trials. But also women with a history of abnormal Pap tests or genital warts were also excluded. So this is a bit of a lower risk group. And also, if a woman had more than five lifetime partners, she was also excluded. So this is a somewhat lower risk group. So we have to think about this with generalizability. And enrollment was several years ago. So I told you the interim results from the Phase 3 trials were published in May of 2007, and they were published in the New England Journal. I'm going to give you the results, the interim results from these trials. I'll also tell you that there was an editorial that accompanied these trials, and I'm going to tell you what that editorial said. And I was asked to be the guest editorialist to write about these trials, so I'll tell you about what I said with my colleague at UCSF. So this is the Future 1 trial, that trial of 5,000 women. You remember this diagram, so I'm going to give you all the results from these three populations. First of all, Future 1 measured vulvar, vaginal, and perianal lesions. Future 2 did not, so I'll tell you the results here. Vulvar, vaginal, perianal lesions were reduced by 34%. The incidence in the vaccine group was 3.8%, and in the placebo group was 5.8%, so that difference is 2% absolute risk difference, which is a number needed to treat of 50. How many of you are familiar with this concept of the number needed to treat? Some of you. What that means, it answers the question, how many patients need to be vaccinated for one woman to avoid getting genital warts? Okay, so it gives you some idea of absolute risk. And I find it very helpful, more than these relative risks. So I told you that they had two outcomes. One is efficacy against disease associated with HPV 6, 11, 16, or 18. The disease here is defined as CIN1 or worse. I already told you that CIN1 is transient, so some people might not believe that this is a very important outcome, and many people would want to focus on CIN3 or worse as being the most stable cancer precursor. So in this group, these are the women who were naive at entry. These are the women who got all the doses, who had no protocol violations. There was 100% protection against CIN1 or worse associated with the vaccine HPV types. This was the big news. Everyone was very excited about this. And this is quite stunning if you think about it. We don't have such high efficacies for many interventions in medicine. So there were 0 outcomes in the vaccine group and 2.6% in the other group, and this is the number needed to treat here. And in the second population, again, similar to the first, but they didn't get all 3 doses necessarily. They had a smaller efficacy, but really extremely high efficacy. Then what about the intention to treat population? In this group, they had a much less efficacy, but that's because a lot of these women came into the study and they already had disease on their cervix, right? So that's why this efficacy is a lot lower. But still, 55% decrease in your risk is pretty substantial. Your risk going from 5.7% down to 2.6%. So that's measurable. That has some value to it. Again, most of this is CIN1 or worse. So in this per protocol group, the question might be, well, what about efficacy against disease regardless of the HPV type? So this might answer the question if a woman says, if I get vaccinated, what's the chance I'm going to be protected from cervical cancer precursors, regardless of whether it's related to 16 or 18? Well, we don't have the answer to this because this was not reported in the study, so hopefully we'll get that when the final results are reported. It was also not reported for this group. It was reported for the intention to treat group, everyone in the trial, and the efficacy is lower because, again, these women had prevalent disease. And most of this was against CIN1. But of course, this is a small study compared to Future 2, so let's look at the Future 2 results. But before we do that, let me talk a little bit about adverse events, because those are kind of the benefits. There were no differences in vaccine-related events, discontinue rates, or death. There were some higher injection site events in the vaccine group and some more fever. One thing I found a little curious was that one woman in the vaccine group who was 22 years old was diagnosed with a vulvar cancer. And vulvar cancer is an HPV-related cancer. And that is a very unusual occurrence in general, and it's absolutely incredibly unusual in a 22-year-old. In the US, the average age of getting vulvar cancer is the age of 68. And the risk of vulvar cancer incidence in the whole population is 2 per 100,000. So since it occurred in a young woman in the trial, it made me kind of concerned about that. So when I first saw that, I was a little cautious. So what about the Future 2 trial? Same issue of the New England Journal, interim results, larger study. Now, what Future 2 did is they didn't report these external genital warts, but they did report CIN2 or worse. They didn't report CIN1 or worse. So this is CIN2 or worse. So many people would say, well, this is more clinically important. Others would say, really, I want to know CIN3 or worse as the most robust cancer surrogate. So for this first population, they looked at efficacy against disease associated with HPV 16 and 18. It's not 6, 11, 16, and 18 for this trial. It's only 16 and 18. And what they found is they found high efficacy. There was one patient in the vaccine group who had CIN3 that was associated with the vaccine type. So it wasn't 100%, but it was close. In the next population, they still had high efficacy. And then in the intention to treat population, they had a lower efficacy, just as they saw in the Future 1 trial. And what about the other side? So what about efficacy against disease regardless of HPV type? This is overall CIN. And in the PPS population, again, this was not reported. I don't know why this is not reported, but it's certainly something that if anyone's interested in policy, they would be interested in knowing what the effect of vaccination is on overall CIN, to know something about its effectiveness and its cost effectiveness. Not reported again for this group. Then when you looked at for the intention to treat population, there was a 17% decrease in that risk, and it was just barely statistically significant. So this might be an idea that if we vaccinated women like the women in this trial who had prevalent disease and other partners, et cetera, that we might get a fairly modest effect of vaccination, but not a huge effect in terms of overall CIN. But again, very high efficacy amongst naive women looking at disease associated with the vaccine types. Now remember that this vaccine is designed to only target disease associated with 16 and 18. And 16 and 18 are very bad viral types. So it shouldn't be surprising that it does not affect overall CIN very much at all, unless there's a hope that this vaccine has some cross protection against other types, but there is no evidence that that's true. So let me give you the data in another way to look at it. These are the figures from the Future 2 trial, and let me orient you to the slide. This is the cumulative incidence of disease defined as CIN2 or worse, and this is disease associated with HPV 16 or 18. This is the placebo group, and this is the vaccine group. So what you should notice is there's no difference in the first year of the trial for this outcome, and that's because this includes women who had prevalent disease. this is the intention to treat analysis. This is everyone in the trial. So there's no difference because at the randomization at the beginning of the visit, you have equal distribution of CIN2 on the cervixes of the women who get into the trial, regardless of which group they're assigned to. But then over time, if you start looking at new cases of CIN2 associated with 16 and 18, amongst vaccinated women, this curve gets flat. This means these women start getting some protection from new cases of 16 and 18 related dysplasia. But in the placebo group, they continue to have 16 and 18 related dysplasia. Now the next slide I'm going to show you is the effect of vaccination versus placebo on any CIN, regardless of HPV type. This is just overall CIN. And here we have, in the vaccine group, we don't have the leveling off because this is just disease due to any type. You see there's a difference, but you see there's still an increasing risk of dysplasia in those women, but this is probably because they're having dysplasia related to HPV types that are not included in the vaccine. So there's not a cross protection or a long-standing protection against all CIN. So if you look at something like this, you say, well, gosh, there seems to be some effect, but we certainly have to continue to screen women, right? Because they're still having a substantial amount of dysplasia. They're just not having 16 and 18 related dysplasias as much. What about adverse events here? There were injection site events that were similar. In this publication, they combined the pregnancy outcomes from both of the trials into the Future 2 publication, and they showed there was no congenital anomalies, but they did say that women who had an estimated date of conception that was within 30 days of vaccination, that they did have a higher risk of having congenital abnormalities. And this was kind of unusual. It was statistically significant. There were 5 in the vaccine group, and there were none in the placebo group. But there was no pattern among the types of anomalies. If you look at them, they seemed to not be related to one another. So the teratologists, or the people who look at birth defects at CDC, looked at all of them and said, yes, these are defects to some degree, but they're not related to each other, so we don't think that this is a real effect. And that certainly could be true. Some of them were things like a club foot, another was a renal anomaly, so they didn't feel like those were related. I personally was kind of this is the second cautionary note that I saw. It made me really want to know the final phase 3 trial results, just to make sure that this is not a sustained effect. The reason why I think this is not a real effect, although it's statistically significant, is that there are no cases of congenital anomalies in the placebo group, and you would expect there would be some, because we see congenital anomalies in normal pregnancies. But since there were none, I think that's just a chance imbalance of outcomes. But again, no big deal. We can wait for the results and see if that was something that was sustained or something that was true. So I'm going to tell you the current guidelines in the United States. I mentioned them before, but now I'm going to tell you what the wording is. This is the guideline published by CDC. This is the ACIP guideline that I mentioned. And they say, and you're going to see some of these things I asked you to vote on in the first slide, because what I didn't tell you is those voting options were the various guidelines in the United States. They say recommend vaccination of 11 to 12-year-old girls, recommend catch-up vaccination up to the age of 26, and that you can vaccinate as young as age 9. So very generous policy. Pretty much vaccinate everyone up to the age of 26, regardless of any countervailing conditions. Except they do say it's not recommended for use in pregnancy. What they don't say is whether or not we should be using it in women who are trying to get pregnant, right? Because remember, the anomalies I told you about occurred in women who were not pregnant at the time of vaccination, but got pregnant shortly thereafter. So they're silent about that issue. They say you can give it to women with equivocal or abnormal pap tests. You can give it to a woman who's breastfeeding. You can give it to immunocompromised women, but they're not sure if it really works very well. So that is the CDC recommendation. Now, the American Cancer Society also came out with recommendations, and they're different. And you're going to recognize these as being voting option B. The first was voting option A from CDC. Similar recommendations, except they are not sure that we should be vaccinating women between the ages of 18 and 26. They think we should vaccinate up to the age of 18, but after the age of 18, we should have a conversation with our patients about what their likelihood of benefiting is. And they say that there are 3 major pieces of information that are missing for them to be able to recommend it up to 26. The first is there's a limited effect of vaccination on overall CIN2 in women with 2 to 4 lifetime partners. What this means is that they were saying that 17% decrease in risk that I showed you in the Future 2 trial, they thought that was a fairly small decrease. Now, I would say, well, what about the decrease in overall dysplasia amongst those other 2 groups for which the data are not reported? So how come that's not a problem? But I don't know why they didn't address that. There was no data about the efficacy in women with more than 4 lifetime partners, and they were unsure that given that this vaccine is really very expensive, that vaccinating women who were unlikely to benefit was going to be cost effective, right? In the US, this vaccine costs $360 American per woman. It's $120 per dose. And remember that in the United States, we spend about $4 billion on cervical cancer screening in general, and we're not going to change the way we screen. So this is on top of that. And if you do the calculation, it's about $1 billion extra per year to cover vaccinations in this age group. So it's a very expensive investment. So if you have to kind of be sure that you're getting something that gives you good value on the other end, if you have a lot of screening in your population. I have one other piece of information, because what we were trying to do is figure out to some degree which women are not very good candidates for vaccination. And when I say this, I mean, are there certain groups of women who are so unlikely to benefit that by vaccinating them, we're either just wasting our money or we're increasing harms in them. And I'm a firm believer there's absolutely no such thing as a harmless intervention. But that's just the way, I'm kind of the do no harm principle believer in medicine. So I'm very stingy with prevention in general. I think we have to have a high burden of proof for preventive interventions. So this is a publication from about a year ago where they pulled the results from all the women in these trials who were in the North American sites. They pulled results from the phase 2 trial I told you about and the Future 1 and 2 phase 3 trials, but they also included results from a monovalent vaccine. So it's a little weird to do an analysis like this, right? Because some of the interventions are different, and some of the populations are different, and some of the protocols could be certainly different. So take that. Remember that this is a little unusual to do this kind of an analysis. But I present it to you because it does shed a little light potentially on some of the outcomes that we're talking about. This is about 5,500 women. They were followed for about 2.5 years. And what they looked at, I'm going to orient you to this table, and I apologize that it's a little complicated, but I'll draw your attention to the relevant components. So you'll recognize some of these outcomes from the Future 2 and Future 1 trials. The HPV type-specific endpoints, and this is 16-18 related dysplasia, or endpoints regardless of causal HPV types. This is overall effect. So the question to some degree might be, what about these young women, women under 18? This is what the American Cancer Society says that we should target our interventions to. What do we know about the effect? Well, there appears to be a decrease in 16-18 related dysplasia, but in this analysis it's not statistically significant, probably because of a small number of people. there is a substantial decrease in 6, 11, 16, 18 related dysplasia, and decrease in genital warts, although it's not significant. And then none of these other outcomes was statistically significant, which is kind of unusual, but I think it's just a power problem. I want you to also notice that there appears to be an increase in CIN of any grade in women in this age group who got vaccinated. But of course that is probably based on a small number of outcomes, and we don't know exactly what the point estimate was, but it wasn't statistically significant. Anytime you see less than 0 here, that means there were more bad outcomes in the vaccine group, okay? But again, none of these is statistically significant. The next question is, what about women with more than 4 partners? And the question here is, if a woman has a lot of partners, does she not benefit from vaccination? If you look at, regardless of HPV types, there doesn't appear to be any significant difference, although, again, there's not a lot of power in these analyses. There appears to be some difference in CIN2 or 3, which is an important cancer surrogate, but it's of a less magnitude than in other subgroups. Now, if you look at type-specific HPV infection, it appears to not make a great deal of difference, the number of partners, even 0 partners. I found that very confusing and very odd. But what I most was compelled about is this question about whether or not we should vaccinate women if we know that they have an abnormal pap smear. Right? Because we know abnormal pap smears are largely the cause of HPV infection. So, is there any evidence that if we vaccinate these women that we will actually have some therapeutic benefit or any effect at all? And what is kind of interesting here is that many of these outcomes were in the direction of harm, but none of them was statistically significant. So this was not a compelling reason to vaccinate women who have abnormal pap smears. It was potentially a reason to not do so. This is something we can clinically measure. I can't clinically measure a woman's number of lifetime partners. So this is something I think that we should pay attention to. But again, this is something more suggestive of something to think about, hypothesis driving rather than practice changing, because it is a subgroup analysis from a lot of pooled studies. I don't know what to make of this, but it does raise my eyebrows a bit in terms of whether or not we should be vaccinating women with an abnormal pap smear. But I'd be interested in hearing anyone else's opinion about that, because I think it's kind of interesting. I told you I run the colposcopy clinic, so as you can imagine, many of my patients who come to me, they all have abnormal pap smears, they're all being under surveillance, and they all have colposcopy, and they all ask me about getting vaccinated against HPV. So this is a real huge question, and I've been very tempered in my response. So here's what I think the further information is that we need. We need the final results from the phase 3 trials. Many people are very surprised when I tell them that the phase 3 trials of this study are not or have not been reported yet. I think the trials are over, but I haven't seen the final results. I think they're going to be available at some point, but that would be important for us to see so that we can make sure about the weighting of risks and benefits. The key benefits I want to know about are whether or not the vaccine decreases overall CIN3. I want to know whether there's any suggestion that the vaccine stops working after a certain period of time, where the efficacy wanes over time. That would be important to know. I also want to make sure there were no more vulvar cancers that occurred in the vaccine group or other odd cancer outcomes. I think that would be important. And I want to make sure that these effect on congenital anomalies was in fact just a random occurrence. So I want to see that resolved, because I think that has some practice implications that I'm going to mention to you in a moment. So the second is, I mentioned overall rates of CIN3 or worse. I would love to know if the vaccine affects a woman's likelihood of getting an abnormal pap smear. And I would like to know if it affects the likelihood of her getting colposcopy, because if vaccination decreases the chance of abnormal pap smears, decreases the chance of colposcopy, decreases the chance of needing a treatment on the cervix, that would be very valuable. And that could be a way for us to justify some of the cost of vaccination if we were going to save it by saving these procedures. But again, there's no evidence yet that this is true. And I will say that the monovalent vaccine trial that I mentioned earlier as part of that pooled result showed no effect of vaccination on cytologic abnormalities. So I think we have to wait to see if this is true. But if it is true, that would be a great benefit. And we need cost-effectiveness analyses from the trial results. Right now, we have cost-effectiveness analyses, but they are based on the most optimistic scenarios of the vaccine. 70% decrease in risk of cancer, lifelong immunity. I told you that my colleague and I wrote the editorial for these articles when they came out, and I just put the exact text here because I just wanted to impress upon you that we didn't know exactly what to say. It's very hard to interpret interim results from trials and make a very firm conclusion. So we looked at it this way. We said, on one hand, the vaccine has high efficacy against certain HPV types that cause an important life-threatening disease, and it appears to be safe. Delaying vaccination may mean that many women will miss an opportunity for long-lasting protection. That's the urgency about this. If we don't act now, some women are going to become exposed and they're going to miss an opportunity to be vaccinated. That's the urgency component. But on the other hand, we may need a cautious approach in light of important unanswered questions about vaccine efficacy, how long the protection lasts, and any adverse events that may emerge over time that we're just not aware of. And again, I think we have some suggestion of adverse events among some subgroups, but we haven't quite figured that out yet. We did conclude by saying that HPV vaccination has the potential for profound public health benefit, but only if the most optimistic scenario of benefit is realized. Because we wanted people to understand that we believed that this to be potentially a triumph of medical advancement, a real triumph of medicine. Or we thought it could potentially be a multi-billion-dollar experiment where we weren't quite sure of what the results are. We're not really quite sure in which direction this is going to fall, but we thought that we were at a state of evidence where we couldn't say definitively how the risks and the benefits were weighed against one another. I'm going to have you vote again. You ready? Same options. So you have, if you were sleeping, you have to wake up and vote. So option A, vaccinate all girls and women 11 to 12 to 26. This is CDC's recommendation, the AICP recommendation. How many of you vote for that? A couple. It's very hard to go against CDC, I'll tell you. Because when you're a practitioner in the United States and, CDC says to do something and you say, well, I don't think that, it's really difficult to do that. But I've emailed CDC a lot and told them the position they've put me in and that it's difficult. And they've been very sympathetic to it, and I've been trying to get them to be a little more thoughtful about their guidelines. Oh, sorry. So option B, vaccinate all girls and women aged 11 to 12 to the age of 18. This is the American Cancer Society recommendation. Any enthusiasm for that? A couple. Okay. What about option C, vaccinate virginal girls? All the way up to the age of 26. Some enthusiasm for that. And what about D, no vaccination at this time, which is some enthusiasm for that as well. I have to tell you, there's every time I've done this session, there's been just a variety of opinions about it, even beforehand, but there does seem to be a change. There seems to be more enthusiasm, this is my general impression, for trying to only vaccinate virgins. That seems to be a general enthusiasm, and there also seems to be more people who become uncertain. I'm going to ask you to vote on two more things. Should you recommend contraception in sexually active women until the vaccine series is completed? So how many of you would recommend that if you had a patient who was sexually active and she wanted vaccination, you were going to vaccinate her? How many would you recommend that she not try to get pregnant or try to avoid pregnancy until the vaccine series is over? So lots of enthusiasm for that. That's not a part of the current guidelines, and I've asked CDC to consider thinking about that, and they told me in their last email to me that there was no consensus of opinion, which is good. That means they're thinking about it. Because beforehand everyone had a consensus of opinion. And the next is, should you recommend vaccination in women aged 26 to 45? So this is outside of the age limit. If you have a patient who comes to you and says, you know, I've had one lifetime sexual partner and now I am moving on. And age 35, and she wants to be protected from any new things her new partner may be exposing her to. So how many of you would vaccinate her? Maybe, a couple. All right, so I have no more slides. I'm certainly interested in answering any questions you have, and I thank you for your attention. Thanks.
I have a question from Dr. Prolan for. Can you? There's a microphone for you.
First of all, I want to congratulate you on a most beautiful talk. I have one question that is coming up in some papers. Do you have any thoughts on vaccination on boys?
So the question is about vaccinating boys. And let me say that, first of all, there are trials of vaccination in boys and men that haven't been published yet, but they're ongoing, and interim results have been presented in some fora. So that will probably be part of guidelines in the future. I think there are two questions to think about. First of all, I think if you take CDC's approach and look at this as a vaccine against a very bad virus, that you might make a compelling argument, as long as it's not extremely expensive and it's safe, that you should vaccinate everyone in a cohort, not just the girls, but also the boys, to have broad herd immunity for a population. Now, the countervailing argument is that that would double the cost of vaccination. And we don't know that there are very compelling reasons to vaccinate men because they have very rare outcomes associated with HPV of any great clinical import in terms of cancer. Now, they do get genital warts, but you would have to make sure that the choice of vaccine was one that included covering 6 and 11, which are the wart-causing types of HPV. So I think that we're going to see more information about that. There's going to be more discussion about that, and the discussion is going to be very rich.
Dr. Paulo Naldi. Please.
Hi, George. Congratulations on your very nice talk. I'd like to put some questions and consideration. As you may know, for sure, at the market now it's appearing two different vaccines. You have exposed brilliant data from quadrivalent vaccine. And so the principle is the same. It was developed at the National Cancer Institute. We brought here Douglas Lowy, the director of National Cancer Institute in '99. She done a speech here. And so I'm involved with the development of vaccine, but the other vaccine, the bivalent vaccine. And the first one, question. Formulation, and I'm involved with this vaccine by the information of National Cancer Institute by the difference of the formulation. And the first question, do you think the formula and the composition of these two different vaccines may provide some benefits to patient? I understand that it's not available, the bivalent vaccine Cervarix at the US, but there are a lot of data published. And so quadrivalent vaccine show it's a weak vaccine at the point of protection. As we have shown in your slide, at the first 6 months, we have a decrease of antibodies, and so some lesions may appear in the vaccine that we are working. We have data published over 6.5 years, and it shows protection against disease, high-grade disease, to 90 to 100%. This, I think, shows the different. Next month will be published, I think, by Lancet, a comparison between the two vaccines in the United States. It is a head-to-head study that will show the difference. So I'd like to hear your thought on these briefly considerations. And at the end, a final question is, with a vaccine that protects over than 10 years or 6.4 years, like we have the vaccine that we are working, it may not be a good approach at the public health level. A mother bring her daughter to be vaccinated, and with this movement to vaccination, she will be stimulated to perform his PEP test, because cervical cancer prevention, what we need is coverage. And you know, here in Brazil and the other Latin American countries, we have low coverage to cervical cancer prevention. So this is an optimal time that we may promote primary prevention and secondary prevention.
Great.
Thank you.
Thank you for your comments. Well, you're right. Of course, there are going to be two vaccines in the U.S. market at some point. And I think that there's going to suddenly be a big conversation around evidence that we really haven't had yet. Because in the U.S., there's only been one vaccine. So I will bet that when we have two, that people are really going to start looking at the evidence behind them, because they're going to need to make a choice between the two. Now, of course, the best way to make a choice between two agents is to actually have a randomized trial that compares them head-to-head, looking at the outcomes, various outcomes. So that would be important. Now, when I say various outcomes, I think that probably of the most clinical interest will be clinical outcomes, whether or not one leads to less CIN overall, or even less CIN related to vaccine HPV types compared to the other one. I think people are going to get a little more interested in this effect of vaccination on overall CIN. If in fact Cervarix has cross-protection, as it's been shown in some of the Lancet papers, then you would imagine that it has a greater effect on overall CIN. It has an effect, Cervarix has effects that were not seen in the quadrivalent vaccine or not even reported. So it's very hard to compare them. The most challenging thing is that the analyses and the analytic plans are different between the two. So it's very hard to make a head-to-head comparison looking at two separate studies and two separate publications. That's why it's so important, I think, to have one trial, same methods, the only thing different is the different interventions. I think we have a lot to learn about vaccination, no question. I think this issue of the length of duration of protection is going to be important. Hopefully we'll have more information about that. I think that also it would be a shame if we put all of our investment in the promise of vaccine and forgot screening amongst high-risk women who've never been screened. So I would echo what you said, that a great model would be for women to bring in their kids of vaccination age, they get vaccinated, and the woman gets her first pap smear or some other cervical cancer screening, so that we're combining vaccination with some high-impact screening program that we know has proven benefit.
I have just one more question as permission for Professor Sergio. If I have one more question from Picon. Picon, please.
Professor Sawaya, congratulations on your talk. It was brilliant. And I just have a few comments on the question you made to the audience, just for you to do not have this wrong impression. I would say that 100% of the students here would say yes to that question about NNT, okay? Because they really know what is NNT, and they really know also what is NNH. NNH. And when we talk about NNH, as you mentioned, that comes to us as a lot of questions. And one question that I have is, what do we really know about when you take out those those two serotypes of HPV, what would happen with the other serotypes? There are so many. And what do we know about what would happen with the cervical cells 10 years after, 20 years after getting out this serotype that are supposed to be the main cause of cancer?
Right. I think that that's a valid question. And we raised this question in our editorial. We actually put in an analogy. And I'll tell it to you because we ended up not putting it in the paper. We took it out. I said, you know, it's kind of like a human being in a cage with a lion and a tiger and a bear. And then someone comes along and takes the lion and the tiger out of the cage. But you're still in there with the bear. So we were wondering whether or not targeting two high-risk types was really going to be sufficient to protect women from cervical cancer because we have at least 15 oncogenic viruses. Now, it could well be that the bear is a little more friendly than the lion and the tiger, that maybe 16 and 18 related dysplasia has the biggest oncogenic potential, and that maybe dysplasia related to these other types is just not as virulent. But we really don't know. When you look at I will tell you that there is some data, it's only in the FDA docket available on the website, but when you look at the incidence of dysplasia due to the non-vaccine HPV types, it seemed to be higher in the vaccine group. So that is another question that we need to have answered. I say appears to be higher because it was higher, but it wasn't statistically significant, so we couldn't say anything about it, but it did make us a little aware. My colleague, Karen Smith-McCune, is a molecular biologist, and she's actually quite concerned that vaccination may increase the risk of dysplasia associated with the non-vaccine HPV types through mechanisms related to inflammation. But again, that's just a hypothesis. The proof is in the pudding. We'll just have to see. I personally don't think that that's going to be a big problem. But when I saw that one case of vulvar cancer in the 20-year-old patient, I got very nervous about something like that. So again, this is why I take a very cautious approach and a very tempered approach, because for the United States, I don't think cervical cancer is an emergency that would allow us or mandate that we let down our standards of evidence-based practice to do something in a quick manner. I just don't see why that's the case here. For some other countries that don't have good screening programs, I can see how the urgency might be greater because they might not want to miss an entire generation while we're waiting to figure out benefits and harms who may have benefited. But again, it's a double-edged sword. It could be more harmful than beneficial, or it could just be a neutral proposition. We just don't know. We're at this, what I call the tender state of evidence, where there's a lot of enthusiasm, there's a lot of very optimistic statements and evidence, but we don't have the full picture to be able to make broad-based population policies. Yes, so my answer is D.
Great, thank you very much.
Sure.
Okay, I think it's time. I would like to finish. I want to thank for the audience for coming, and Dr. Sawaya, thank you very much indeed, and hope to see you again here.
Thank you.